Um, so basically, sickle cell, you know that it's a prevalent genetic disorder in the United States. About 75,000 Americans are affected by the disease. And there is association of significant mortality. It's a result of a mutation, as you know, of the beta globulin gene. And it's estimated between 8 to 10% of the African Americans carry the sickle cell trait. And it's roughly in the population of the American population, 50% of these individuals with the sickle cell develop anemia and the crisis and die before the age of 20. However, there are others who do not have the crisis and they don't have the severe form of the anemia can live to go up to 40. The most common people who you see sickle cell anemia families is not only the African Americans, but the Spanish-speaking areas like in South America, Cuban, Caribbean, Central America, and the Saudi Arabia, India, Mediterranean countries like Turkey, Greece, and Italy are also have this cell trait that is carried through the line. Basically, they have the homogeneous form, which is the dominant, and you have the recessive form. And you have the heterogeneous form, which is hemoglobin A and hemoglobin S. It's when it's the recessive form, when you have two hemoglobin SS together, that's when you get the most severe form of the sickle cell, and you see the sickle cell crisis, and you see the many complications of sickle cell and death. The form that's the heterogeneous, you can have hemoglobin A and C. They're carriers. They really don't have sickle cell crises, and they can live a long, normal life without any problems. So the trait, if a patient comes, you two are not really involved in the emergency room, but if a patient comes in and I have sickle cell disease, and you find that they have hemoglobin A and S, which is they have the trait, and they say they're in a crisis, they don't have crises, okay? They do not have crises. They generally live a long, good, normal life. It's when two traits, if two people who are carrying the trait of the sickle cell, S and A, and they get together, they have a high risk of having children with the sickle cell anemia or the sickle cell disease that leads to the crisis, okay? So with the care of today, and the concern and of these patients, the intervention is early, and so they have a fairly normal life, and they can live up to 40 to 50. This is the hemoglobin SS type. Basic guidelines for somebody who had sickle cell anemia or the sickle cell disease, and you want to avoid a sickle cell crisis. They have to be really concentrating on avoiding dehydration. That is the biggest thing. Even if they have high fevers and they have to avoid dehydration. They have to avoid high stress situations, the high altitudes. The biggest thing is that they should not always go into the emergency room. Should not be their primary care. I mean, there are a lot of people who are non-compliant, go and use the emergency room as like their primary care office, but that's not how they should really use it to get the best care and to prolong their life as possible. And on the biggest problem with the sickle cell disease patients who have sickle cell crises, who end up in the emergency room, who need pain medications, is that they get targeted as being drug-seeking, that they're addicted, and they could get treated badly and not get the pain relief that they need during a crisis, and a crisis can be very painful. And so it is advised, and if you have patients that way, it's advised for them to go with somebody, a parent, a significant other, into the emergency room so they do get the care that they need, because they're big targets for that kind of thinking. The results of the sickle cells can cause erythrostasis, which leads to blood viscosity, thickening of the blood, reducing in the flow, leading to hypoxia, so they can't have enough oxygen delivered, causing adhesions of the cells so they clot, and leading to clots, vascular clots everywhere. Therefore, leading to more sickling. So the reason for when they have dehydration, the blood becomes thicker. So and then the risks increases for a sickle cell anemia trait disease person to develop a crisis very easily. So if you hydrate it and you let the flow increase, thin out the blood, you reduce your chances of having a sickle crisis. The signs, of course, can be, it's a pain. It's severe pain. It could present like an acute chest syndrome depending on the area. It can cause cerebrovascular accidents, strokes, depending if it's clotting in the brain. You can have splenic renal dysfunctions. It depends if they clot in the spleen or in the kidney regions. They lead to chronic anemia. And of course, they are very highly susceptible to infections. And you can see jaundice, pallor as consequences. They can have clots and events occurring in the hands and foot, toes, which severe tenderness and swelling in them can occur. They can develop leg ulcers, organomegaly, cardiac failure, bone pain, abdominal pains. It's a very painful situation for them. The combination of pain symptoms can be purely a nociceptive type of a pain. It could be a neuropathic pain. Some people have a combination of both, or one or the other. So in the nociceptive pain group, it's basically caused by the neural pathways in response to tissue damage, and the neuropathic pain group is caused by primary lesion of the dysfunction of the nervous system. So some people can be just nociceptive-like, some people can be neuropathic, and then they're a group that's just a combo. The nociceptive pain group tends to be postoperative pain. It can be like mechanical pain, like low back pain. And in the neuropathic pain, you can have like sports injuries, central post-stroke syndromes, TMJs, polyneuropathies like diabetes, HIV kind of type presentations. The symptoms. It occurs both in the children and in the adults, and it's really mainly is because of the blockade of blood and low oxygen, and a painful event or crisis may occur in any part of the body, organ, joint, fingers, toes, everywhere that you can think of, in the abdomen, chest. It's a painful crisis. Some people have it less than a year. Some people may have it 15 or more, ending up going to emergency rooms multiple times. The pain can be acute. That means it's a sudden lasting, or they can have an event that's going to last a long time and be in pain, and they need to be admitted to the hospital with IV PCA, hydration, etc. In the acute pain type of the sickle cell crisis, it's a sudden onset. It can be a mild ache to a very severe. It can last from hours to a few days. And with complication, it can have complications. It can have poor treatment, and that could lead to this crisis lasting for weeks. In the chronic form, it usually lasts 3 to 6 months or longer, and the pain can be very hard to bear. It could be very draining on the patient, and of course, it's going to limit all their activities of daily living. And then there's some people who have a combination of both that occurs. Some sickle cell patients are very lucky that they only maybe have one crisis a year. I've had a patient who used to have a crisis before I started treatment on him every month, about 5 times, and he would be in the emergency room. We will go over what we found on how to help some of these people to reduce their episodes of crisis, to reduce their episodes of going to the emergency room for care for crisis. Some of the laboratory findings that can help you determine the severity of a sickle cell disease patient is if they have decreased hemoglobin levels, which could result in cardiomyopathies, strokes, spleen situations. If they have decreased level of hemoglobin F, which could lead to autoinfarcts, leg ulcers, acute chest syndrome. If they have an increased level of hemocrat, they can lead to vaso-occlusive pain frequency, osteonecrosis. That could happen anywhere, like in the femoral head. It could happen in the shoulder, anywhere they are high risk. Increase in the white blood cell count can lead to hemorrhagic strokes. Increase in vaso-occlusive pain frequency can lead to premature death. The patient that I used to treat unfortunately passed away at the age of 27 due to renal failure. The best thing we can do is to manage a crisis, give them high levels of folate during and after, analgesia during and after, hydration prior to a crisis to prevent, during, and hopefully to continue. Some of the situations they have to be careful about if they're going through surgery, and the anesthesiologist is aware on how to avoid general anesthesia, on the importance of the IV sedation and what they need to use a lot of caution with, the importance of giving them supplemental oxygen and the IV fluids to avoid the barbiturates and to avoid suppression of this respiratory system, because they can end up with respiratory acute failure. The biggest thing is pain control. Also to avoid a crisis. Aspirin could cause crisis. So it's not really recommended that you give high doses of aspirin to a patient who has sickle cell disease, because everybody thinks aspirin is safe. Give lots of aspirin. The biggest thing is opioid medications can be helpful in the crisis. Patients who have many crises can sometimes benefit from taking opioid medications daily. In fact, there's many studies out and done by our own doctor who used to work here, Dr. Shayova, did many studies on the sickle cell population and opioid treatment, in where they found that if you maintain them on opioid medications, maintain them a certain level of pain control, you do reduce the number of crises, you do reduce the number that the patient needs to go to the emergency room. In my own patient that I saw, before he used to go 4 to 5 times a month, he would come maybe every 3 months. He probably might have not ever gone to once. So it does reduce the cycle of going into crises, into the emergency room. So pain control is very important with these patients. And we're done with the sickle cell. Okay. We start on HIV/AIDS association. This is a very big slide amount that I have on the slide. So I'm going to zoom through certain parts and just concentrate on the parts that are more important to us at this point. Our retrovirus, as we've seen, a little retrovirus. The background, that HIV is a retrovirus. I'm not going to read through the whole thing. The biggest thing is that it comes from 2 related retroviruses, viruses, H1N1 and HIV2. And because of this, it can result in many clinical manifestations, and varying from asymptomatic carriers to a severe, debilitating, fatal disorder related to the defect of the cell-mediated immunity. HA1 causes most cases of AIDS in the Western Hemisphere, Europe, Asia, and Central Southeast Africa. HIV2 is principally agent of AIDS in West Africa and appears to be less virulent than the HIV1. And in some areas of West Africa, both are present. 1981, it was considered an epidemic, and it was very challenging. They didn't know how to handle it. There was a lot of fear around HIV at that time. Right now, it has plateaued out with the treatments, advertisement, prophylactic, knowledge of everything that you need to do. But the thing is, they have noted now it's an increasing in the heterosexual population. It's basically about right now 8.5 per 100,000 population is positive. The number of new HIV infections in 2006 has been noted to be 56,300 new ones. This is not counting the old already positive. Approximately 1.1 million people currently have HIV infection in the United States, of course. The increase in death is it's related to the virus, but not exactly. It's cirrhosis, liver failure, cancer, and end organ failure from these patients. The death due to HIV/AIDS rates remain high in women, African American, and Hispanic males, mainly because of non-compliance to treatment. So they pass away a lot earlier. I have patients who are in their 80s with HIV and still functioning. The basic thing that we worry about is when the CD4 count goes below the level of 200, which causes them to be vulnerable to many infections and other complications leading to AIDS. Of course, we could do many diagnostic testing to prove it, and I'm not going to go through that. The prognosis, if they have follow through and carefully take their medications, do good follow-ups, and are careful, they can live a productive, long, pain-free, not complication-free, but pain-free for a while, and maybe even prolonged becoming in AIDS, developing syndrome from it. Some of the manifestations we see can be neurological. It could be course over the years, and as we treat the HIV-positive patients with medications and they're living a lot longer, we're seeing more of their problems that develop. Neurological symptoms, they're common and can be the first manifestation. In fact, I had a patient who did not know he was HIV positive, a young man, came in with peripheral neuropathy with no other predisposing factor. No diabetes, no hypothyroidism, no other comorbidities, but just peripheral neuropathy. And when I addressed the issue of HIV, he became panicky, and then he left, and I didn't see him for another year. He comes back for follow-up after a year, and he says, "Doc, you're right. I got tested, and I'm HIV positive." And he was very upset with me when I first had addressed him. Sorry to hear, but that's can present. So there are HIV-related dementias, and then you can have progressive multifocal leukoencephalopathies can occur, and the manifestations of those. These are not what I'm going to concentrate on. We want to go to the pain aspect, but you need to know that these are also presentation of a patient who HIV, he's been on meds, whose CD4 count can drop and develop AIDS syndrome, which can occur, and they can end up with all of these neurological manifestations from multitude variable things, from like dementias to lymphomas to encephalitis, can all develop with the patient when their CD4 counts are going low. That's why it's important, if you have a patient that you're treating for pain or for anything else, to keep in mind and ask them frequently, periodically at least, how's your CD4 count? How's the viral load? Those are very important to know. And it's important to know, especially if you're planning on doing kind of interventional procedures on them. If their CD4 count is below 200, there's a higher risk for these events. They can develop myopathies, because the steroid that you inject them will decrease their CD4 count further. So if they're starting at 200 and below and you decide to do a steroid injection, epidural, nerve block, whatever the reason might be, even a joint injection, you're introducing steroid with them and they're at 200 or below, that steroid is going to drop their level down. And if, let's say, you repeat it 3-4 times, and each time you do, let's say, a joint injection, which you're not even thinking that it's being too complicated or too much to give to them, you can end up with steroid myopathy easily with these patients. They can develop Cushingoid syndrome because you're dropping it more. There are other neurological manifestations, which I'm not going to go through all of them, but they are prone to all of these. The neuropathies can, as I said, could be the first manifestation of an HIV infection, and it could be days to weeks of onset. It could be with pain or sensory loss, can lead to weakness mild to moderate. It could be symmetrical, it could be asymmetrical in distribution, and it's basically 83% of axonal loss is what's occurring. So if you send them for an EMG study. The common peripheral manifestation is basically the inflammatory demyelinating polyneuropathy form, and then there's the distal symmetric polyneuropathy form. About 33% of these are people with diagnosis of AIDS. You can also have degenerative distal axonal forms, and mainly presentation, the patient presents with burning, numbness, tingling, pain, dysesthesia, and of course absent ankle jerks or depressed. The other thing is they can have some wasting of the intrinsic muscles. Of course, the diagnosis of AIDS, it comes with a CD4 count of less than 100, and then they're prone to other neurological manifestations of mononeuritis, multiplex. They can also develop quadra equina syndrome as well. Urinary incontinence. So, quick exam on a patient, are you able to hold your urine or bowels? You can just quickly ask them all of these questions very easily and to find out, are they having any problems? They're also very prone to oral candiditis, oral thrush, which can be very painful for them for swallowing. And then you could do a swish and swallow or magic mouthwash kind of a remedy for them. It could be just the oral mucosa, or it could follow through all the way down. And it can be very painful for them for eating, swallowing, doing anything like that. Could be extremely painful. The other things they can be prone to is herpes. It could be from the herpes simplex in the ulcers, and it could persist, and they can have shingles also, very severe. They're also prone to sarcoma, lymphomas. These are some of the manifestations. HIV patients are also prone to cardiomyopathy and pulmonary issues. I'm not going to go through each one of these more medical issues, but just to have an idea that just because a patient walks in and they look healthy, have HIV positive, and you're treating them just for pain, and you're giving them maybe methadone, or you're going to give them something else. But in your mind, you should know that they are prone to some of these. How are their CD4 counts? Do they have any more other comorbidities? These are some things you need to ask, because remember the risks of the methadone with the QT-QTC interval. Some things you need to be aware of. And the respiratory issues you need to be aware of. Now, also they can end up with glucose issues and developing diabetes can occur in patients who are receiving the treatment. Remember, the HIV medications also have a lot of side effects. So, but they are given even though with the risk of a lot of side effects because of the ratio risk to benefit. Abnormalities related to impaired glucose tolerance can occur as early as 2 weeks after the start of a therapy, and may be linked to most closely to the PI use of the antivirals. Not going through the studies. The biggest thing is if when you'll see this very commonly is the lipodystrophic syndrome that can develop in patients who are on HIV medications. And when you see that, it's just basically, I think I have the picture somewhere. It's basically deposition, inappropriate deposition of fat. Usually commonplace is in the abdominal area. It looks like the, like if they're being, what is the one with the African, they were Western. They have a very big abdomen, thin legs, and thin arms. And I forgot. So when you see those accumulation of fat, you also have to worry about cardio arterial. I can't talk now. You have to worry about problems with arteriosclerosis, and you need to worry about other deposition of fat, other areas, which could cause problems. So this is something to look at patients. I've seen it a lot when I was doing the Peter Kruger clinic with the HIV patients. It was very common. And it depends on the duration of the infection they're on, the duration of the medications they're on. Sometimes when their primary infectious disease doctor notices the development occurring, they will try to rotate. Sometimes it works, sometimes it doesn't. But they do not stop giving them the antivirals because of it. But patients can become non-compliant because they're seeing that occurring with the medication, therefore causing an increased risk in the side effects and then developing AIDS because of the drop on the CD4 count. One big thing they've found that can help in reducing this event is physical therapy, exercise. They have shown that can decrease the girth of the abdominal situation. So exercise has been shown to be very beneficial. So you can maybe push your patients to do some exercising, maybe first send them to physical therapy so they do it appropriately and not harm themselves in the gym. Because of the biggest thing of the inappropriate deposition of the fat causes a lot of psychosocial issues with them. Their appearance, they're looking at them, so they go into more depression, causes more other issues in that sense. And of course, non-compliance, especially if it's a female. And all of a sudden, they're developing this big abdomen. Everybody says, "Are you pregnant?" That can stop anybody from taking anything. There's also hematological disorders that are also associated with this group, which I'm not going to concentrate on today. The myopathies, you can have early forms when we don't treat them, but they're there. The later onset of form of myopathies associated with AIDS can be related to some of the antivirals. And if you find that the myopathies develop and you think it's related to the ACT medication, by stopping it, it can resolve within 3 to 4 months. They could have developed necrotizing myopathies, and of course the HIV wasting with the fatigue, muscle wasting that is also known, been seen. It's type 2 type of atrophy that occurs with them. They can also are prone to bone disorders of osteoporosis and osteopenia. They can also have high risk of osteonecrosis that can occur with these patients. So they do have a lot of complications that can happen to them. The reason why we're seeing more of these complications because they're being treated with the HIV medications, they're living longer, so they're seeing complications not only because of the HIV virus itself, but also side effects of the medications that they need to take. The common types of pain that we see could be peripheral neuropathy. Number one, the most complaints, of course, we see peripheral neuropathy is in the hands and the feet. Numbness, tingling is the manifestation that they feel, and it's related to nerve damage that can be related by the HIV drugs, other conditions like they could develop diabetes, or the HIV virus itself. Now, the ones that most commonly had caused the peripheral neuropathy were the early form of the antivirals, which are not really used as much today. The other big problem is abdominal pain. They're also prone to developing a lot of abdominal pain, cramping. Could be because related to side effects of the drugs. The drugs that sometimes patients have very difficulty drinking and taking them causes a lot of gastric irritations as well. They can develop such like irritable bowel syndromes. They can also could develop inflammation of the pancreas with the medications, and also by drinking alcohol in combination of these medications as well. In women, they've found that they're more commonly higher risk for urinary and bladder infections. They can also have headaches associated. They could be a mild to severe to moderate to severe forms. They could be from pressure to throbbing. They can present like migraines. They can be manifestation of the severe forms because maybe they're developing a lymphoma, a tumor in the brain area, and sometimes the reason unknown why they develop such headaches. And it could be also related to a side effects of the HIV medications that they're taking. There are also, of course, you can see joint, muscle, bone pains, herpes pain as postherpetic neuralgia. Now, when they develop herpes zoster, a person who is not immunocompromised can develop a herpes zoster. It can be very localized in a nice band form and fit a nice dermatome and be perfectly gone. They might have postherpetic neuralgia. They might not develop postherpetic neuralgia. However, the HIV patients tend to have herpes zoster severe. It's not a nice band of a dermatomal distribution. It could be widespread. It could be very severe. It could last longer, and they develop severe pain. They are higher risk for developing postherpetic neuralgia and complications for them. They're also a higher risk for repeat of the zoster. They can also develop skin rashes due to the side effects of the medications also. The options we know, you can treat these patients with non-opioid medications, your Tylenols, your NSAIDs, your topical creams, your patches, your antidepressants, your Cymbalta, SSRIs or SNRIs, your Neuronsins, your Lyricas, Topamax for their symptoms. Then you can go for the opioid treatment options as well. From long-actings of any morphines to the short-acting. The choice of opioids should be related to their predisposition condition. I used to do a lot of methadone before. Now with the high risk of the QT-QTC issues, might not be the best option. If they have kidney or liver issues going on, OxyContin, Dilaudid might not be the best option. If they have more respiratory issues, maybe a fentanyl might be a better option. If they're developing oral thrush frequently, maybe a fentanyl patch might be a better option. So you have to look at the patient and see what might be the best option for what treatment. And sometimes just remaining on a non-opioid antidepressant, anticonvulsants for addressing their peripheral neuropathies or other things which they might not need to go into the opioid realm for treatment. As when they say when we start treatment, they're talking about more of the antivirals. Now, the most common way they do it is they like to treat somebody who has recent infection, a recent onset of HIV syndrome, which can be like a flu-like symptom for the patient, and they just recently, within 6 months, have becoming HIV positive. And any time with any kind of opportunistic infection that they might have. Or a patient with a CD4 count equal to or less than 500 is when they like to start treatment, or a high viral load, which is more than 10,000. And of course, any person with HIV positive who's willing to take or accept the therapy. To swallow these medications is very hard. I mean, I've talked to my patients in the HIV clinic. It's very hard. They experience a lot of nausea, and it's a big structured thing that they have in order to be able to swallow these pills. It takes a lot. Now that they've come with combo pills, before you had to take 3 different ones, now they have new formulations where 3 are in one pill. So it makes it a little easier for them to do it. And some of these are the reverse transcriptase inhibitors. They even came out more since I last did this. They have the proteinase inhibitors. And they most likely do dual therapies. They can do triple therapies. They have many combinations. The patients, before they even start these therapies, they find if a patient fits the category of starting an antiviral, what they do is they test to see which one are they able to, which one of the medications is the HIV virus that patient is susceptible to. So they do a whole big slew of tests. And in fact, I had a couple of patients who were resistant to all. And they had a very hard time getting something on board for him. And his manifestation was he started to develop severe muscular wasting, frequent oral thrush, frequent visits to the emergency room, and unfortunately, about a year afterwards, he passed away. As these antivirals are not a cure. They just maintain the CD4 count at a certain level. They maintain the viral load at a certain level, and hopefully enough levels that allows the patient to have some productive life, some quality of life, without having opportunistic infections, without having to go to the hospital and prolong their life to some degree. In the end, however, they do succumb to either the side effects of the medications, to the complications of the virus itself. They do not die of the virus per se, but they did die of the complications caused by the virus and their medications. People are living longer, and they are seeing the toxicities. They are seeing all these complications more so. As I said, I have a patient who's 80 years old and still without having an AIDS syndrome yet. And this is the dystrophy. This is how it presents. Some people have it more, some people have it less. Its deposition is very typical. You see the temporal wasting. They can have very typical temporal wasting on some of these patients. The biggest thing we do as pain management is we try to give them quality of life. And so that their life can be productive to a degree, so they can at least do what they want to do and enjoy whatever they want to enjoy. And thank you.